Hello, and welcome to the quarterly Parkinson's webinar series brought to you by Cure Parkinson's, the Journal of Parkinson's Disease, and the University of Edinburgh. My name is Tilo Kunath from the Centre for Regenerative Medicine in Edinburgh, Scotland, and I'm delighted to be hosting today's session. So today we're going to focus on deep brain stimulation. It's a treatment that's already improved the lives of many people with Parkinson's. We'll be looking at next generation therapies such as adaptive deep brain stimulation or adaptive DBS. And we're also going to be looking at this big question: can DBS be disease modifying? So to explore this, we're joined by three outstanding panelists who will introduce themselves shortly. So as we're going along, please post any questions you have in the Q&A box, and we'll try to answer as many as possible live. But keep in mind that we won't be able to answer any personal questions directly related to your Parkinson's. Some of the questions will be handled by Dr. Simon Stott, Director of Research at Cure Parkinson's. But first, we'll start off with Ben, please.
Hello, everyone. Thank you, Tilo. Thank you to the Cure Parkinson's Cure Parkinson, for having us. Yeah, my name is Benjamin Stetcher, and the reason why I'm here is because I was diagnosed with Parkinson's about 12 years ago. At the time, I was living and working in China. I soon found out though that China's not a great place to live with this disease long term, so I came back home. And but I was very determined to find what were the best therapies for people like myself, and what could I do to help other patients like myself as well. I then traveled the world. I went almost everywhere I could, looking for the best therapies that might be available in the future. That's where I saw Tilo for the first time in Edinburgh. It was great to climb Arthur's seat with him back then and see with his son as well. So I got to know a lot of the researchers. I got to know a lot of the community behind Parkinson's as well that's trying to push forward better therapies for people like myself. Um, However, funny enough, I found the best therapies back in my hometown in Toronto with Alfonso Fasano, who will introduce himself shortly. And I found them in DBS as well. So 4 years ago, I got this new kind of adaptive deep brain stimulator implanted in me, which we'll talk more about later on. And yeah, I think that's enough for me for now.
Great, Ben.
The next person.
Lovely to see you again. Next, Rhonda, please.
So, hi, my name is Rhonda McFleder, and I am a junior professor at the University Hospital of Würzburg in Germany. And I studied immunology as a postbac at the National Institute of Health, and then did a MD PhD in neurobiology at the University of Massachusetts. And I had the opportunity to join my neurology and immunology background here in Würzburg in Germany to study how the immune system is modulating disease in Parkinson's disease. And I'm really excited to talk about our most recent research that is showing how deep brain stimulation may be modulating the immune system and Parkinson's disease progression.
Brilliant, brilliant. Thank you very much, Rhonda. And Alfonso, please.
Yes, thank you. Thanks for the invitation, actually. I'm really honored to be with you all today. My name is Alfonso Fasano. I'm professor of neurology in Toronto. We're happy to meet Ben, but I'm also professor of neurology in Milan at Humanitas University. So I sort of wear two hats in two different continents, which gives me the opportunity to learn what's new in Europe, what's new in North America, and trying to blend the things. And amongst the many things I happen to learn in life, a lot comes from my interactions with Ben, that one day emailed me, and here we are. And so we actually described what we went through as a patient, as a doctor, in a book that we recently published, and maybe we'll have also time to talk about it. I didn't say it, but obviously most of my practice has to do with deep brain stimulation and the use of other advanced technologies for the treatment of movement disorders and Parkinson's in particular. Thanks again.
Great. Lovely to have all three of you with us. So, Alfonso, can we just jump right into it? What is deep brain stimulation? What is it good for? And what is it not good for?
Sure. The easiest way to explain deep brain stimulation is to use the analogy of cardiac pacemakers. This is a pacemaker for the brain. Usually two little wires are inserted in the brain of people with different diseases, usually movement disorders, but this can be used for epilepsy, for some psychiatric conditions, and it's been around for over 3 decades, but research, the very first research actually started much earlier. So it is now an established treatment, especially when it comes to Parkinson's disease. And I need to emphasize that because a lot of people think this is experimental. Instead, this is one of the treatments with the highest level of evidence for Parkinson's. So this is what DBS is. I also missed to say that the electrodes are connected to a battery, which is also a little computer that is placed under the collarbone in the chest. And in terms of what's good for, this helps involuntary movements, tremor, dyskinesias, the motor fluctuations of the disease, and it's pretty good at doing that, often allowing medication reductions. What's not good for is improving typical problems that are seen with disease progression. For example, memory problems of Parkinson's disease, balance disorders, freezing of gait sometimes. This is the reason why when we assess people who are candidates for this treatment, we perform a levodopa challenge, because a sort of a rule to follow is that what responds to levodopa will respond to deep brain stimulation. The difference is that deep brain stimulation will be constant. There are some exceptions to this rule. First, tremor sometimes doesn't respond to levodopa well, and yet DBS is very effective. Dyskinesias are caused by levodopa, and they respond well to DBS. The other flip of the coin are issues like speech. Speech tends to respond better to medications than deep brain stimulation, and a few other things. For example, motivation, feeling well, sometimes responds better to medications than stimulation, and that's the reason why we don't want to use one or another treatment. We usually combine treatments. On purpose, I didn't address whether this changes the natural progression of the disease, because I know we will be talking about this later on. But when I discuss in general this with my patients, I usually say this is a treatment, it's not the cure of the disease. So it's good for particular problems, but it's not good for to address the evolution in the disease, and that's very individual. Everybody has their own disease, and we don't know upfront what's going to happen to every single individual.
Yeah, that's excellent. I like that you made the point this is not an experimental treatment, it's an established treatment. There is a issue about access in different places and different postcodes, but how specifically does DBS relieve symptoms?
Well, again, we need to go symptom by symptom, and also depends on what the neurologist does when they program the device. The effect can be quite specific and tailored to patients' needs. Sometimes actually people have different groups that they can use. They have a little remote control, which is basically a smartphone, and they can switch from one group to another, and they can have a group for that is excellent for tremor, but maybe that group comes with some speech problem. And so if they're on the call, on a phone call or on a meeting, they will switch to another program that is more specific to speech. But in general, stiffness, muscle stiffness, tremor, involuntary movements, slowness, they respond very well to DBS. And this is a question that I get often. The question is, for how long? And I tend to say forever. We have enough data at this point to say so. It becomes a bit more difficult when we're talking about fine motor skills, because they improve, but to a certain extent. For example, and we have seen some of such cases in the past, some dancer or musicians or even avid swimmers, they will do much better in general, but then they will tell me that when they're doing their activities that require a lot of coordination, like finger motion, they can tell that DBS is not able to help them. In fact, they're a little worse. But for day-to-day activities, getting up from a chair, walking, going somewhere, this is extremely effective, and importantly, it's working all and night long. And another thing that people have as a result of this treatment is better sleep. We always say that Parkinson's doesn't go to sleep, and in fact keeps people awake at night sometimes with stiffness, dystonia, cramps, slowness. People are not able to even go to the bathroom. DBS being active also during the night help people accomplish these tasks, and as a result, also sleep quality improves.
Yeah. Thank you. Improved sleep sounds almost disease modifying to me. Rhonda, what aspects of Parkinson's biology does DBS interact with?
Hi. What we know in Parkinson's disease is that there is a loss of neurons in one area of the brain called the substantia nigra. And this loss of neurons is associated with aggregation of alpha-synuclein and other proteins within these neurons. And Alfonso, we know, can maybe talk about sort of the larger network effects, but what we study in our group and what we've seen from preclinical models is that stimulation, deep brain stimulation, can actually modify this neurodegeneration and stop this neurodegeneration in animal models. And also in cell culture models, this seems to be associated with loss of aggregation of proteins such as alpha-synuclein, either by stopping alpha-synuclein from aggregating or by increased release of aggregates from the neurons. And these are important biological effects that could cause a disease-modifying effect of deep brain stimulation.
Yeah, that's really exciting. I think we're going to get into that a bit more. Ben, there's been questions about you already about how old are you? When have you been diagnosed? If you feel comfortable, you can answer that. But my first question is, why did you opt for DBS?
Sure. So I'm 41 years old right now. I was 37 when I got this deep brain stimulator implanted in me. The reason why I got DBS, and it's something that I actually learned by working with Alfonso and by working with some of his colleagues as well, especially with Alberto Espe in Cincinnati, that I don't have something called Parkinson's. And I don't think this word Parkinson's is very helpful when you have it for a period of time as well, because you learn more specifically what type of disease that you really have. And I have something called nigrostriatal degeneration, which is this form of Parkinson's that's it's usually more motor dominant, meaning that it affects your motor symptoms almost primarily. And this was the case for me. This is why DBS, I was such a good candidate for DBS in particular. This is where I think this whole field has to move towards. We have to kind of do away with some of these labels that we have, like Parkinson's, and move to us more towards a world in which we're able to more specifically identify what is going wrong in each individual patient. And to do that, you have to learn their symptomology. And to get there, though, you need to surround yourself with great people. You need a team of people around you that are able to help you and that know enough about, obviously, about treating diseases like Parkinson's, that they're able to help you identify what is going wrong in your specific case. And that's how I was able to get to the point where, one, I learned that DBS is probably the best therapy for me very early on in the course of my disease, which is why I sought out Alfonso over 10 years ago, why I became part of the lab, or became part of his clinic at Toronto Western Hospital. Um, but then, so yeah, I think that answers the question.
Thank you. I think there's a lot of people will be interested to hear what your experience was like going through getting DBS, and what was your first conversations like with Alfonso?
So this is something we go into very much in what Alfonso alluded to before in the book that we wrote. I go into very deeply all the gory details behind the procedure itself and what it was like to actually sit in the chair and as someone's drilling a hole through your brain. So there's a lot of to go into there. The book is called Reprogramming the Brain. You can find it on Amazon or by going to the Springer link as well. And the authors are sitting here in front of you, so you can just type our names and you can find it there as well. But so it's hard for me to explain exactly what it was like to get DBS because it's a very traumatic experience for a lot of patients in particular. It was very painful to go through. There's moments in which you feel agony. There's moments of ecstasy as well. And there's ups and downs you ride all along the way. Um, so yeah, I can talk about like some of the more traumatic moments, some of the moments that people might be more afraid of. I don't know how helpful that would be, but it might be something that some people might get something out of.
Maybe don't go to the gory details, but actually a really important question is what should patients consider whether should they choose DBS or not? And reading your book is a really good way to get all the details, but what should a person be considering?
So one, they have to have a great team of people around them. If you don't have, so there's kind of three pillars of DBS that I go into in the book as well. One is you have to have a great neurological team around you. You have to have a great clinical staff that has a long history of this of being able to treat this disease properly. Two, obviously, you need a great surgical team as well. Surgeons that have a lot of experience getting this electrode down in the right part of your brain, because it's not in the right. And it's very important that it's in the right part of the brain as well. Because if they can't get it down to the right spot in the brain, then you're obviously not going to be able to benefit from this technology. Then the third and often the most overlooked one is you have to have a great family environment to come home to at the end of the day, because there's a lot of moments along the way. I've experienced this plenty of times where you're not able to fend for yourself as well as you might like to, where you need a supportive environment to come home to in particular. So if you don't have those three things, I would say you might want to consider another therapy because they're crucial to making sure that you get through this in as good a shape as possible.
Yeah, your point about the family environment, or the supportive environment around is a really good one that I hadn't considered before. I'm going to go to Rhonda now because I'm really interested to hear about how DBS might be disease modifying. So you hinted to that when you discussed it, but how could DBS actually in theory, slow down Parkinson's?
Yeah, so when what we've been studying is in particular deep brain stimulation in the subthalamic nucleus, so the STN. And what we see here is that what we know is STN-DBS can inhibit the neurons in the STN, the subthalamic nucleus, among other things. And in Parkinson's disease, this is helpful because these neurons can be overactive and send too many signals into the substantia nigra. And the substantia nigra is, again, where the neurons are degenerating. And so then if we can inhibit these neurons that are usually overactive, then you have sort of less input into the substantia nigra. And one idea is maybe less stress there. And why this would be disease modifying is if you have less stress, perhaps the neurons can die less. And as I hinted at before, what we've seen in cell culture models is that you may have also less aggregation of alpha-synuclein. And we know this aggregation of the proteins within the substantia nigra is really underlying the neurodegeneration. And so then if we have a mechanism to stop the aggregation and the stress on these neurons, this could potentially be a way to stop the neurons from dying and having a disease modifying effect.
Great, thank you. Your thoughts, Alfonso, on the same question?
Yeah, so I think this is a difficult topic because the one thing that doctors try to do, and Ben can tell you, is to give realistic expectations to people going for these procedures. This is a great treatment, it works. But if we inflate the expectations, then the net result is disappointment and depression. And even in the past, we have seen cases of suicide, unfortunately. So when a patient asks me, is this going to change my disease? My answer is no. And that's because the data we have so far comes from animal models. And unfortunately, animal models don't have Parkinson's. Parkinson's, whatever we call it, doesn't exist in these animals. We create a fake Parkinson's. We induce the Parkinson's, what we think Parkinson's is in these animals. But as you heard from Ben, Parkinson's is just a label. So there are many different reasons people have the disease. And in fact, I can tell you that in some cases, DBS can also speed up the evolution of the disease. This is an ongoing research, but some genetic mutations seem to make the brain more frail. And so when you do a brain operation in these particular brains, instead of helping, you increase the chance that these people will develop memory problems. So it is a complex topic. And so in practical terms, my answer is no, because I don't want to give false expectations to people. However, even without going into animal models, I think we need to look at what happens to people that receive DBS, and we compare them to people who didn't do DBS, who didn't receive DBS. Now, this is very difficult to do in practical terms, because it would be like having a room full of patients that are candidates for DBS, and you say, okay, 50% of this room gets DBS, the other 50% doesn't get DBS because I want to see whether you get worse. I want to see whether you die earlier. Obviously, this is not ethical. But some studies have been done in the past looking at those people whom were offered DBS and they refused. So in principle, they were candidates, but the patient, for reasons of, usually they're afraid of surgery or family reasons, who knows what, refused to have surgery. And what's been seen is that their long-term progression is different. They tend to die earlier. But at the same time, we need to acknowledge that these people, they may have said no for a reason. Maybe they were poorer. They could not, back to your social economic comment you made before, maybe they could not afford to even travel to the hospitals, to the city where the hospital was, and that's the simple reason they say no. And as we know, poor economical status is also associated with higher mortality. So it is difficult to really say with 100% certainty in humans if the evolution of the disease changes. I personally think it does, and the reason I'm saying so is because even if we don't want to allude to a particular disease-modifying effect of the actual electrical field in the brain, so the fact that there's electricity in the brain, think about sleeping better. You said it. If you sleep better, your cognition is better. If you reduce medication, your chance of hallucinating, having psychosis, falling reduces. And falls is a major risk factor for death in Parkinson's. But even more importantly, if you get surgery and you move better and you don't use this improvement just staying home and watching TV, but instead you go to the gym, and because you are moving better, you take advantage of it and you exercise more, you get more aerobic exercise. And we know that aerobic exercise changes the disease progression. So even if per se DBS doesn't change the disease, it gives you that ability in an indirect way to have a better life. And with that, you have a better long-term prognosis.
I think that was
Yeah, I
very
just wanted to
well
add.
said. Yeah, I'm gonna bring in Ben in a minute, but direct benefits of DBS, maybe that might be controversial, but the electrical field may be having some disease modification, but the indirect benefits, wow. Yeah, I'm convinced. Okay, Ben, what do you have to say?
No, I just wanted to, his last point was the one that I wanted to mention, that so DBS, it might not by itself be disease modifying, but it allows you to move, it allows you to live again, it allows you primarily to exercise. And exercise has been shown to be disease modifying. I know that it's been the case for me in particular, because I go to the gym now every day, and I know I can only do that because of DBS. I mean, I saw Alfonso in the clinic 2 days ago, that during every clinical visit, there's a short period of time where I have to turn off my DBS. So I got to see what I would look like if I didn't have this at all in me, and I was immediately tense. I couldn't. It was unbearable, really, to live like that. And so yeah, just another plug for exercise and how great exercise can really be to make sure that each individual gets the amount of exercise that they need. So DBS, what it allowed me to do really, and what I believe has modified my disease, has been the ability to move and the ability to exercise again. And yeah, sorry.
Very, very well said. I'm really, really pleased to hear that. Okay, I'm interested in, Rhonda, your research about DBS and the interaction with the immune system, and why might this be important for Parkinson's?
Yes, and so our most recent study demonstrated what was already known, is that in Parkinson's disease, we know that we don't just have problems with the neurons, we also have problems with the immune cells. And there seems to be a shift towards the dangerous pro-inflammatory immune cells. And these pro-inflammatory immune cells start to go into the brain. In particular, T cells is what I'm interested in. And these go into the brain, and we think they lead to the neurodegeneration that occurs there. And so then what's interesting is that you don't just have immune changes in the brain, but we can also detect these changes in the blood. And this is where I think Ben and Alfonso also mentioned this, is one problem why we don't consider deep brain stimulation to be disease modifying is we have no biomarker for neurodegeneration, something that we can measure in the blood that tells us what's going on in the brain. And this is why I like immune cells, because they're telling us what's going on in the brain potentially based on our preclinical data. And what we could see is that deep brain stimulation then can decrease the immune cells in our animal models in the brain, but also deep brain stimulation could modify the immune changes in the blood. And this is important because these immune changes in the blood directly are associated with neurodegeneration in the brain. And now then from this data, we could move forward into patients treated with deep brain stimulation. And then we could also see that these patients, just like our animal models, also have a reversal of these dangerous pro-inflammatory immune changes in the blood. And this is sort of a hint in the blood that perhaps deep brain stimulation is having a modification of disease processes, particularly immune process, but also maybe neurodegeneration in patients and not just in our animals.
Great, thank you. Yeah, I think the patient blood data from people with and without DBS, the immune changes is really, really interesting. We actually mentioned adaptive DBS, but we haven't explained it yet. So I'm going to ask Alfonso to describe adaptive DBS, which is the DBS that Ben actually received. What is this adaptive DBS?
I was going to say Ben can probably even tell you better than me what it is because he's feeling it. But adaptive stimulation, it is the name says. It's a stimulation that adapts, so adjusts the strength of the stimulation depending on what's going on in the brain. And this is the result of some major discoveries that we had in the past. So the first one, in terms of biomarker, we know that there's a particular neuronal signature of Parkinson. So when the brain is more Parkinsonian, neurons tends to being activated with a certain frequency that we call beta. So the more beta frequency there is in the brain, the more Parkinson's we see outside. So because we have this biomarker, then the logical consequence of this is to use it, recording it, to determine how much stimulation is needed. So current technologies, which is now approved in many countries, including Europe, allow us to stimulate the brain either constantly, which is still very good and standard of care, or activate this function whereby the stimulator doesn't just stimulate, but records and responds to the recording. And this has the potential to reduce battery consumption, to reduce side effects coming from excessive stimulation. I mentioned speech, for example, or also freezing may come as a result of too much stimulation that is indeed needed, or adjusting the level when levodopa kicks in and maybe you need less stimulation, otherwise you have dyskinesias, the stimulator will go down. So it is quite promising. It is something that actually was explored for years. And the very first paper that I'm aware of came from the UK in the 80s, 1980 actually, where two researchers used a stimulator in the thalamus for tremor, and they used another electrode in the muscle of the patient. So when the patient was moving the hand, the stimulator will turn on, and the tremor will be improved only during the movement. So that would be, it was actually quite a clever idea. But this is to say that it's a natural evolution of this technology, exactly as it happened with the cardiac pacemakers. Cardiac pacemakers initially were just pacing the heart. Now we have pacemakers that are really ECG. They record the heart and respond to what's going on in the heart, depending on, minute by minute, depending on what's going on. We will see. I just want to add a note that this is extremely new, and we're excited. We've wrote about this in the book. Ben is the first patient in Canada who underwent adaptive stimulation. But I've seen also a lot of people with frustration recently because they think they missed the boat because they don't have an adaptive stimulator. DBS is still a great treatment. The good old bread and butter stimulation still works. And this is just an additional tool that can be used in some cases.
Yeah. Thank you. I think that's a really good point, that DBS is excellent, and don't hold off getting DBS to wait for adaptive if you've been offered it. Ben, what's your experience with adaptive DBS?
So it's been mainly positive. I've had it on now for almost 4 years. I don't even remember what continuous was like because it's been so long that I've been on this adaptive program that it's really my only basis point for for DBS in general. There's one point that I want to clarify though with Alfonso, and that is about this. So how often you need to get the battery changed? Because from my experience anyway, it's actually been draining it much faster than the conventional DBS would have. And it's been the one downside that's actually made me some days I rethink whether or not I should be using adaptive versus continuous. Although the experience, I obviously get a lot of benefit throughout the day. Like even right now, I'm not taking any L-DOPA just because I'm only reliant on my adaptive deep brain simulator to give me everything that I need. And for the most part, does most of the things that I do need. But I wonder if Alfonso might want to comment more on that, on this idea that it actually might be draining battery faster in some patients anyways.
Yeah, thank you, Ben. I don't want to get too technical because I'm sure there are many other questions to go through, but sensing per se, the fact that the recording is going on constantly, obviously, that doesn't drain the battery much. It's really a much stimulation is needed. Without getting in too much into your personal stuff, you are taking, if anything, zero levodopa. So you're taking very little medication. So this means that stimulation in the brain needs to be higher to control everything. And so that's what drains the battery most, how much stimulation is actually being used. And in case that's a challenge to people, we also need to say that some devices allowing adaptive stimulation are rechargeable, and they can last up to 15 years. This comes with other problems because the patient needs to charge themselves, otherwise the stimulation doesn't work. But this is to say that when the battery doesn't last long enough, and we say 5 years, 4 years will be okay, then there is an option to consider. And in Canada, that's not the case because in Canada, adaptive stimulation is not approved, and therefore we cannot use the rechargeable system, but that's a different story.
Yeah, great, thank you. We're just about to jump into the questions. We've got lots, but just before we do, Rhonda, do you have any thoughts of adaptive DBS? Could it be more disease modifying, or could it be disease modifying?
Yeah, so yeah, thank you. That's a good question. So the short answer is we don't know, and but we're working on it. It's the same with the chronic deep brain stimulation. Then yeah, we need some sort of biomarker to say that we are actually modifying disease. And I would think that adaptive deep brain stimulation, my hypothesis would be that it should be as neuroprotective minimally as the chronic deep brain stimulation. But we need some sort of biomarker. And that's why I'm really excited about our most recent research that was using immune cells in the blood and showing also with the large data set that the immune cells could potentially be a biomarker for neurodegeneration in the blood. And I'm excited to perhaps look at patients that are receiving adaptive deep brain stimulation to see if they also have if adaptive deep brain stimulation can stop these immune changes similar to what we saw with chronic deep brain stimulation.
Great, thank you so much. So we're going to jump into questions now. And I think the first might be for Alfonso, but maybe also Ben. Would you recommend DBS for early stage Parkinson's for the sake of early intervention? And if you do have DBS, can it be turned into adaptive DBS?
Yeah. First question, it is a question that we asked ourselves, and there's been also a trial in the States. And in this trial in particular, there were people with a disease duration less than 4 years. So these people went to DBS before even they had fluctuations of dyskinesias. I think it is too early to say so. And if I were a patient, I would be so afraid of being operated that I would say, I'm doing so well now, why do I need to have a brain operation right now? DBS, as a matter of fact, from what we know, does a great job in improving the fluctuations and the dyskinesias, the up and down that Parkinson's causes and the tremor. So if a patient happens to have this problem and these problems are affecting the quality of life, this, in my opinion, and also ethically, justifies a brain operation. That a brain operation that is done routinely, hundreds of time on a daily basis. But as any operation, there is some risk that something bad really it happens. It's really rare, but it can happen, and you don't want to be left with the doubts that maybe there was no reason to go there and just carry on with medications, because medications, especially initially, do a very good job. So the answer is I will not do it unless the patient has either fluctuations / dyskinesias or a resistant tremor. As for the other question, depending on the brand that the person has, some devices can be, they can have the feature unlocked. So some devices have the feature of adaptive stimulation already present, and that can be unlocked, but not all the devices have this function enabled. Yes.
That's clear. Ben, you had a comment as well for those questions?
Yeah. So there's one other aspect of this of getting DBS I think needs to be clarified, and maybe Alfonso wants to weigh in on this as well. But it is important, I feel like the patients need to be relatively close to their center if they're going to be operated on, if they're going to receive their care. Because every time I go back to get another programming session done, I leave feeling a little bit better. But it's also reliant on the fact that my team there knows me very, very well. And I have years of experience with that particular team of people as well. I can imagine myself if I were not so lucky to live close to one of these centers, that I would not be as keen to get DBS, because it is important, I feel like, that you have that regular follow-up with your team and that the team does have the time to know you very well. I don't know if Alfonso has anything he wants to say about that, though.
Yeah, that goes back to your pillars. It's a good point, Ben, because also gives me the opportunity to emphasize that nowadays we also have different technologies, in particular a technology that allows the doctor to program the device remotely. For example, I have a patient who lives in Trinidad and Tobago, and she's home, and I'm in my clinic, in my office. I always tell her why she doesn't invite me to ask her why she doesn't invite me to Trinidad. But jokes aside, I program the DBS device while she's so far from me using the internet. And this is helping fill this gap that you identified, and you're absolutely right, also when it comes to geography. And the other reason I'm mentioning this is because this is a technology of a different type of device that doesn't have adaptive stimulation. It's a different tool. It's another useful function in devices without adaptive stimulation. And this is just to say that one of the missions, or one of the goals that we have as physicians, is not only to match the right candidate to the right treatment, DBS, pumps, whatever, but also in each individual person candidate to DBS to identify the best device. So someone living very far from me, I will stay away from the adaptive settings, and I will favor a device that allows me to program them remotely. So that's just to say that technology is good, but also adds some complexity.
Yeah, there's a lot of questions about age and stage. So stage, we've already addressed some. And so very early Parkinson's, you recommend, it's too dramatic of a surgery. But what stage or what age, is there an age cutoff for being a candidate for DBS? And a really good question from Mike Mooney is, he doesn't think it was explained how it actually works. If you could go over that as well. Just repeat that. Maybe Rhonda can ask that one, but if you could talk about the age and, what's the criteria?
Yeah, I was gonna say Rhonda can answer the how it works because it's not an easy question. As for the age, age is a number. I always say that, and some people are very good 70s, and some people are terrible 60s. But in general, obviously, low cutoff, low limit of age, there's no real problem. As a matter of fact, and that's not for Parkinson's, DBS can be done in kids of 5 or 6 years of age. So or for other problems. But for Parkinson's, what's important is the high end of the spectrum, the right side of the curve, which is the age that can cause risks. So they can increase the risk, I should say. So usually I don't have any problem in selecting a DBS candidate until age 65. At this point, you can really do whatever you want. Between 65 and 70, I'm a bit more careful in performing DBS of a target called subthalamus or STN. We heard this term before. It's a spot in the brain. From 70 to 75, I tend to favor more a target called globus pallidus or GPI. From 75 to 80, we do DBS rarely, and if we do, we tend to do DBS of another target called VIM in the thalamus, which is mainly good at improving tremor, not the rest of the problems. So age per se doesn't say much. It is a proxy of how frail the person and the brain is, and this is where we get careful, and that's why we need to be also upfront with patients when they come to see us in terms of risks. Now, just a final comment before Rhonda answers the most difficult question. I don't want people, sometimes people come to me and they say, oh, I'm 69, I've been referred because I know that when I'm 70, you won't do STN for me anymore. And that makes no sense. We need to discuss the present. And I say what I said, age is a number. We can do when you're 70. If you're a good 71, we will do it. So we don't have to perceive this age as in a very OCD way, very obsessive. It's a number, and once we hit the number, we're done. Thankfully, things are a bit more loose.
Thank you. Clear. Rhonda, can you basically describe how DBS works?
Yes, so this is the very difficult question. I think I tried to explain this earlier, and then what we know is that this electrical stimulation can silence these neurons in this STN, the subthalamic nucleus, and among other sort of networks effects. And the STN is a part of a larger network. And we know in Parkinson's disease, the STN is overactive and sending out signals to the substantia nigra, but also throughout the entire network. And when we inhibit the STN, then we can stop this overactivity that's occurring in the STN. And this can improve motor symptoms because you're kind of rebalancing the network.
Yeah, so
I hope this makes more sense.
yeah, so to me, I'm not an expert at all, but I've been explained that the dopaminergic neurons that are dying are inhibitory. They sort of put the brakes on some neurons, and when they die, you have this hyperactivity of some neurons, and the DBS calms down this hyperactivity where the tremor gets reduced, and this overactive neurons essentially get calmed down. Maybe I'm not correct. Okay, but this is sort of my simplistic understanding. So I have a question for you, Ben. Ben, do you combine any other treatment alongside DBS? You did mention about your levodopa dose, but what could be complementary for DBS?
So the only other real thing that I do regularly is I exercise very vigorously almost every morning now. That's really my only other therapy that I take in addition to this deep brain stimulator I have implanted in me. Yeah.
That's great. Yeah, exercise. So I'm a huge advocate for exercise for Parkinson's. So this is a very good question. They reference a study, but I'm not surprised by this study. In the US, they found that Black patients with Parkinson's are less likely to be evaluated for and receive DBS, and they're more likely to receive supplementary care. What are these disparities? What are they like in the UK? I don't know what they're like in the UK, but let's just speak about the US or Canada or Germany. What is these disparities due to?
Maybe I can take this one, or yeah. So because this is a very important point, the concept of equity of care, and I'm lucky enough because of the job I do to travel the world and also see what happens in other regions. Because DBS is basically present almost in every country in the world. A lot needs to be done in Africa, where there are no DBS centers for most part. I mean, North and South Africa, yes, but the vast majority of the continent, there are no DBS centers. They are not even neurologists or Parkinson specialists. That's a bigger problem even. So it is present everywhere in the world. But in some countries, it is not covered. So there is no public reimbursement system, and this is an expensive treatment. I will imagine in terms of just buying devices and all the procedure around and everything, it might cost up to, and that's just an average, $100,000. So in some countries, people need to pay out of pocket. And I've met, because of my travels, a lot of people who are desperate. Some of them have to sell all their belongings for them to receive the treatment. And unfortunately, sometimes they do so, and then the results is not what they hoped. And this is very devastating to the family and to obviously the patient. But in countries where, let's say, there's a system of reimbursement, say public, like in Canada or UK and in Italy, or through insurance, like in the States, still there are problems with access. And obviously, these are even more in the States because not everybody has the insurance willing to afford this cost. But what I usually say, and we also did some research in this, is that the typical patient receiving DBS is the white, wealthy, old men, meaning that minorities, women, people belonging to less favorable socioeconomic status don't get it. And it's a big topic. It's difficult to find a solution, but it's important at least to raise it. And in particular, I want to raise the problem with equity of women, because women, so we know Parkinson's tends to affect mainly men, but obviously affect women too. Let's say 60-40 sort of distribution. But when it comes to DBS, it's about 70-30. So many more men than women. And part of the reason is that the typical caregiver is the spouse, the wife. And unfortunately, husbands, I mean, I met a lot of great husbands, but out there are situations where women with the disease are left alone with not a very supportive care partners. And as you heard from Ben, caregiver is very important to DBS. Then there's research also tapping into why and how people choose what they choose. And there's some research going on in Colorado where they found actually the women with Parkinson's tend to prioritize different things. And so the way doctors explain DBS is more tailored to the male patient, not the female. So there is also some disparity coming from the doctors. So complex topic, but very important.
Yeah, there's health disparities all across the board, but there are unique ones for Parkinson's and DBS. Ben, you had a comment?
Yeah, I have a question actually for Dr. Rhonda McFleder. So you mentioned before about biomarkers and this need for us to find better biological biomarkers for these diseases. And I should caveat this question first by saying that I work for a company called Rune Labs, which has developed a digital biomarker for this particular disease. All you need is an Apple Watch and an Apple iPhone, and then you can start tracking yourself using an app called Strive PD. I'm wondering if you might want to comment on the role that digital biomarkers might actually play in helping us better understand the symptoms of this disease and then better helping us tune even maybe one day devices like DBS.
Okay, thank you, Ben, for the question. So I can say I'm a part of a collaborative research network here in Germany called Retune, and it's a collaboration between doctors here in Würzburg and also at Charité in Düsseldorf. And this is one thing that they're actively working on is digital biomarkers of patient movements, that wearable biomarkers of patient movements that maybe can later feed into how we can adapt deep brain stimulation to improve the movements for those patients. And so I think this is a very important biomarker that we need to be using is how the patient's movements are changing day to day. And this could be later used in order to adapt deep brain stimulation and improve the treatment.
Great. I hope that answers your question, Ben. Alfonso, you did touch about conventional DBS being upgraded to adaptive, and you mentioned about the brands. Can you expand a little bit more on that? So if someone has conventional DBS, can they move or upgrade to adaptive?
Yeah, it depends on the device they received. If they received a device of a particular company within the past 4 years, that device can be upgraded to adaptive. Basically, the company kept it inside the device, locked, waiting for approval. And with approval, it is basically a software upgrade. It's like when you have a phone and you just change the software. Because of the upgrade, your neurologist using the tablet that we use can upgrade it and introduce adaptive. So if you received a device more than 4 years ago, or if you are a recipient of a device from 2 or the other 3 major companies, then adaptive, unfortunately, is not possible. You're not missing the treatment. You still have DBS. Don't worry. There's no reason to panic. But if you happen to have a new device with coming from this company, then it can be upgraded. Sorry, I'm trying to stay brand free because I don't want to necessarily talk about companies. I don't think it's in the best interest of this type of events that we talk about.
Yeah,
brand
so you're not
names.
naming the companies, fine. Really practical question. Someone asked, can you have DBS if you have a pacemaker?
Oh, that's a great one. The answer is yes, but this is actually one of my favorite topics because it's where medicine is going. More and more we're using technology in our daily life. And so, one day people will have a cardiac pacemaker, a brain pacemaker, maybe an inner ear implant to hear better, and who knows what else. So yeah, in theory, it is possible, but there is an issue of compatibility. So sometimes certain settings can't be used. Sometimes charging the system might interfere with the function of the other one. So it is doable, but before doing it, it's important to make sure that the neurologist and the cardiologist, in this case, talk to each other. And importantly, also the representative from companies are involved because they can guide you in the best models, how far from each other they need to be, and many technical aspects. So doable, but before doing it, better to do some homework.
Okay, thank you. Thank you. I guess there are a few other questions is about rechargeable. I know there is rechargeable regular DBS. Is there rechargeable adaptive DBS?
Yes, there is.
I presume there is. Okay. And then a technical question. This is probably for Alfonso. How is work monitoring gamma waves going as well as beta waves? Is this looking like it might give better control?
Okay, so whoever asked this question is probably aware of the paper that was published in, I think, Nature Communication or Nature Medicine, an important journal by a very active group in San Francisco. Philip Starr is the PI, he's a neurosurgeon in San Francisco. And what they did was instead of going after the beta, which we said that beta means Parkinson's, they went after gamma. And gamma means too much treatment. So it's another frequency in the brain. And they explored whether it was better to control the system with beta, meaning more beta, more stimulation, or with gamma, meaning more gamma, less stimulation. This is a bit challenging, however, because they also included in the analysis electrodes placed on top of the cortex. So people had DBS electrodes like anybody else, but two other, let's say, wires above the brain under the skull, and which can be used also to record gamma and beta. So it was a rather complex system. And in fact, they did this in 4 patients only. And in this paper, they showed that their approach is superior to just going after beta. I have some doubts, particularly when we sleep, gamma goes away anyways. So the net result of this is that stimulation goes to the roof at night. So the battery consumption is much worse with this type of approach. And a few other issues, including scalability. You cannot use this easily in every person. But this is just to say that we are just at the beginning. We are learning this many oscillations in the brain, what they do, and technology, thankfully, can give us the opportunity to play with them, so we can determine what type of control paradigm to use. If this happens, do this. If this happens, do that. And little by little, we'll be getting to a better understanding of which one is the best. But I will not say the best in general. Probably every person will have their best biomarker, depending on the conditions they have.
Yeah, thank you. Thank you. I'm going to come back to risks. So there's quite a lot of questions about risks. I think this is, of course, a major concern. But someone mentioned that, suggested that infection, stroke, and death means that the cumulative risk of being worse off after DBS, they're quoting 10% chance of being worse off with DBS. Do you agree with that number? What exactly?
No, I don't agree. Otherwise, I would not be doing it. I would be a criminal. No, it is. We quote a risk of 1% to have bleeding in the brain, and bleeding might mean nothing. You know, sometimes people have a bleeding and they don't even know that. We see the blood on the scan the next day, but then the blood gets reabsorbed, like you can see with any procedure. Different stories when there is a bleeding, and the bleeding is so much that the patient has the symptom of a stroke or the patient dies. Death is extremely rare. One of the surgeons I work with, Dr. Lozano, always makes the analogies. When you buy a ticket to go somewhere with a plane, when you get the ticket, you know that the plane in theory can crash, but it doesn't mean that it happens and it stops you from traveling. Or the person who sells you the ticket, it doesn't say, oh, look, be careful because the plane can crash and you can die. That kind of rarity of events that should not stop us from doing what we're doing. So, which is not saying that there are no risks. It's putting risk into context and explaining what they are. So 1% the bleeding, infection 5%, but an infection is a less troublesome issue because we can use antibiotics, and if the antibiotics are not effective, we remove the system, wait, and then we place another one. And then there are many other little issues. There's a risk of seizure, which doesn't mean having epilepsy. There are many little things, but the major ones are the ones that you cannot get back from. And these are usually the bleedings. And I told you more or less the percentage.
Yeah. Ben, comment.
I have a question for Rhonda and for Alfonso, actually. Coming back to something Alfonso mentioned earlier on about these genetic mutations that might influence whether or not you do DBS on people. Were you referring to the GBA mutation? And if so, I mean, you can talk about me if you want, but what caveats might you add to that comment that you made before?
Okay, Ben, I know you well enough so to know that now you're being the moderator of the session. But remember, we have our moderator, and we should be answering questions of people that are not as familiar as you know. So I don't want to get into the details. Yes, GBA, which is one gene increasing the risk of Parkinson's, is one of the examples that came to my mind. But this is just to say that there are individual factors, genetic in this case, that can change the trajectory of people. And GBA is, again, I don't want to be too technical, but as you know well, there are different types of GBA mutations, and some are more malignant than others. And ironically, well, I don't want to say too much here, but we also need to take into account what GBA mutation we're talking about. It's not just GBA mutated, but GBA mutation with this mutation, and the risk there can be different. It's just a paradigm of where we might need to do in the future. So I call this surgical genomics. So you test the DNA of the patient upfront, and based on the results, you might tell the patient, okay, with this profile, you have this % chance of having this, and blah, blah, blah. It's just a more informed decision tool. It doesn't mean that if you have a GBA mutation, the neurologist will say, no, we don't do it. But it helps the process, because at the end of the day, you know how I perceive my practice, the patient and the family are part of the team, so they need to be involved in the decisional process. And the more information you get, including genetics, the easier it is for them.
Rhonda, did you want to comment as well? Just briefly? We have a running out of time.
Yeah, no, I can just briefly say, I think, yeah, it depends on the patient, obviously, but the studies that we were performing, it was mostly in idiopathic patients, and so we have to look more at patients that have these mutations. But with GBA mutations, they also have aggregation of alpha-synuclein in the brain, and also immune infiltration. So theoretically, it could play a role. Yeah.
Great, thank you. I'm going to answer one of the questions. So someone asked about the difference between deep brain stimulation and stem cell transplantation. So I think Alfonso's point that deep brain stimulation is not experimental. This is an established therapy. It involves electrodes being implanted, and the improvement in symptoms can be quite quick and quite dramatic. Stem cell transplantation is very experimental. It is happening.
It's happening. I can take this also because
Sure,
I'm PI for one of the studies in Toronto. We just published a study. So you said it's experimental. The common misunderstanding is that stem cells are repairing the brain. No, stem cells are an additional source of dopamine to the brain. So we are giving cells producing dopamine to the brain. It's like creating little pumps in the brain that give dopamine. It might be a great treatment. I myself invested in this, but it is experimental, and it's not fixing the brain. It's not repairing the brain. So a lot of people are confusing this because they think it's so simple, and it's not. But I discussed stem cell trial with patients, and one thing I think we need to acknowledge in general is that once you get DBS, most of the clinical trials, I would say all of the clinical trials from that moment on, are not possible for you. So that's something that needs to be clarified to patients, because DBS has such a profound effect on the disease, maybe modifying, who knows, that in clinical trials, including stem cells trials, DBS patients are excluded. So this needs to be said because people need to know that. And the reasons and the ethics of this is not for today's conversation, but if you are extremely interested in clinical trials, then DBS is not for you, simply put.
Yeah. That's a great answer. Okay, we're going to wrap up now. So I want to thank Rhonda McFleder, Ben Stetcher, and Alfonso Fasano for a really stimulating session. So we heard about the basics of DBS. This is a therapy that's been around for over 30 years. It's not experimental. If you have access to it and you have the right support around you and you are a good candidate, the recommendation is to go for it if you're the right candidate. Having it very early to be a preventative measure is not a good idea, according to Alfonso, which was clear. The disease modification aspect of it is really exciting, and Rhonda's research is looking into that, and we're still learning a bit more about that. But the direct disease modification, but the indirect disease modification aspect of DBS looks really, really positive. Improved sleep, you're getting to the gym more often, you're exercising more. All these things should modify the disease and slow it down. And the health disparities is a huge issue. So I didn't mention, but when I was in Greece, they had no DBS available to anyone in Greece. So anyone in Greece would have to travel, right? So this health disparity issue is a major, major issue that it's not easy to address. But I think Ben's experience and Ben's book, and Ben and Alfonso's book, I highly recommend it to really get a firsthand experience of what happens during the conversation between a patient and a neurologist and the whole procedure of DBS. Please check on Amazon or wherever you get your books for that. And finally, I just want to thank everyone. And this will be recorded. This is recorded and will be online for anyone to watch, or if you want to share it, please do so. And we'll see you again next time.
All right, thank you all.